Hello, everybody, and welcome to today's session. Thank you very much for joining us today. My name is Sam, and I'm an academic researcher based at the University of Cambridge. I'm also one of the co-conveners of the Social Power and Mental Health Conference. In a moment, I'm going to hand over to today's chair, who will introduce this session on social inequalities and justice. We do also want to say that the conference covers some challenging topics, and we've asked all presenters to be mindful and to offer content warnings when dealing with potentially emotive or distressing topics. We'd ask that you all be kind and generous with yourselves, and we want you to navigate this session as you need to. If that means stepping away from your screens for a moment in order to do so, then please do so. In challenging times, it is really important that we care for ourselves as well as each other. The conference has been produced in collaboration with local organisations, including CPFT NHS Trust, Lifecraft, and QTI Coalition of Colour. But all of the thinking, planning, and creating has been done by our steering group. And this is a group of local researchers, campaigners, and activists with first-hand experience of mental distress, the psychiatric system, or both. Each session of the conference is chaired by a member of the steering group, and for today's session on social inequalities and justice, I'm delighted to welcome Anne Galpin, who is going to be our chair. So over to you, Anne.
Thank you, Sam, and welcome everyone. My name is Anne Galpin, and I'm on the Social Power and Mental Health Steering Group. I have lived experience of mental distress, autism, and ADHD. The latter only recently diagnosed, so one of the classic cases of misdiagnosis till a mature age. I'm very excited to be chairing this panel on social inequalities and justice, which is an area I work on in my work as co-chair of TUC Disabled Workers Committee and within my union, the National Union of Journalists. Thanks. Now I'm going to ask our speakers to each introduce themselves briefly and give a verbal description, and then we'll return to each speaker speaking in turn. Our first speaker is Rihanna Walcott.
Hi there, I'm Rihanna. I'm a PhD researcher at King's College London, and I'm really delighted to be here. Thank you so much.
Our second speaker is Peter Beresford.
Hello, everybody. It's terrific to be here. I work at the University of East Anglia, and I co-chair Shaping Our Lives, which is a user-led organisation, and my background is as a mental health service user.
And our third speaker is Helen Spandler.
Hi, everyone. Hi, I'm Helen Spandler. I work for the University of Central Lancashire as a professor of mental health studies, and I'm editor of Asylum magazine. I'm here in my house in Manchester.
And our final speaker is Dorothy Gould.
Hi, everyone. I'm a service user, researcher and trainer and consultant. I recently founded a user-led group called Liberation, and I identify as bisexual.
For those of you who are joining from the UK, a list of organisations that can offer support should you become distressed during the presentations can be found at bbc.co.uk/action line. My colleague Ed is just dropping that into the links now. And over now, a warm welcome to our first speaker, Rihanna Walcott.
Hi there, thank you so much for having me, and thank you for that introduction. It's just right. So I am Rihanna, and this talk is about some of my lived experience and some of the research that I've done into BAME mental health access in the UK. So I'd like us to really just, as I go through this talk, to really think about what it would mean in terms of our practice, in terms of our research, in terms of the way that we navigate the mental health systems in the UK. What would it mean to be explicitly and deliberately anti-racist in our approach to our research. So in this presentation, I'll be talking through some of the barriers to accessing mental health care for Black patients in the UK, and tying this to the need for culturally competent research that accounts for the variance in lived experience in order to have useful research outcomes. Thank you. So just a quick introduction. I'm Rihanna Walcott. I'm a PhD researcher at King's College London, and my research looks at how Black people speak online, essentially. I look at social media and I look at digital presentations of identity. I also direct an initiative that seeks to decolonize academic curricula and pedagogy called Project Myopia. I co-edited a book, an anthology called The Colour of Madness, which is now looking towards another printing with a different publisher, so watch this space. So aside from that, some of the research that I do is on Black digital ecosystems of information and the impact that this has on our access to and understanding of healthcare. So that has been very relevant to my work, and I've sort of come to it as a result of my own lived experience, but also seeing how my family and my community navigate access to healthcare. So this image that you've got here is actually something that my younger sister illustrated to accompany an article I wrote for the Welcome collection on what we affectionately know as WhatsApp aunties. So in the image, you've got Dr. Auntie, who sat at a desk with surrounded by things like lemon, honey, and ginger, and Vicks Vapor Rub, with thinking about these WhatsApp messages, these chain messages, disinformation that I'm sure a lot of us received towards the start of the pandemic around safety measures to protect yourself from COVID-19. Gargling with warm salt water kills germs and prevents them from leaking into the lungs. And I found that pretty much still, I am taking on this role within my family of the person who protects everyone from disinformation. Every time a chain message comes along, I patiently debunk the whole thing and explain why, in fact, strapping an onion to your chest isn't going to protect you from COVID, in a way that I think is really important to do inside of our communities, but also to understand exactly the reason why disinformation, willful disinformation, and harmless misinformation do spread more easily within some communities of color. Because, and I'll continue more on this theme later, but I think it's really important to understand that this isn't a moment to laugh at the way that this happens or to be sneering or frustrated about it. It's about understanding the reasons why these digital ecosystems of information exist as they do, understanding the systems and the cultures that have allowed for this pervasive distrust of UK healthcare systems to thrive. And not just happening here in the UK, but also happening across the diaspora. I'm finding myself calling aunties in Barbados and sort of every now and then trying to convince them to take the vaccine, to look after themselves. And it's just really important to understand that there is like long histories of reasons why this kind of medical distrust exists. Next slide, please. So at this point, the issues with a lack of cultural competency can easily be seen from a treatment perspective when it comes to mental health. Statistically, data from the IAPT Improving Access to Psychotherapies program suggests that compared to people from white British backgrounds, people from BAME communities are less likely to use IAPT services, where 13% of IAPT referrals are from BAME groups, whilst 20% of England's population are from BAME groups, are less likely to complete treatment, are less likely to reliably improve, and are less likely to achieve full recovery. So the BABCP, the British Association for Behavioural and Cognitive Psychotherapies, a mouthful, released a Black and Asian minority ethnic survey, Black and Asian minority ethnic service user positive practice guide in 2019 that recommended a number of changes to improve IAPT outcomes, which included adaptations of therapy, of the service more broadly, recommendations on improving engagement with service users and their communities, and recommendations to diversify the workforce and the staffing to better represent the communities served. Next slide, please. So I've conducted some interviews with Black mental health service users to discuss ways in which they were failed by the UK healthcare system. A number of issues came to light, including experiences of fat phobia, the necessity of a careful performance of ill health, and cultural barriers towards seeking medication. Next slide, please. So on this first example by Tyra, she mentions that she feels like race played into those interactions so much. I feel like I was being rushed out of the room when other patients weren't, and that my doctor would barely listen to what I was saying. They only started taking me seriously as a patient, as a human being, when I threatened to contact the medical authority. They want me dead, as far as I'm concerned. When she spoke about her depression, her GP told her to watch TED Talks, daily affirmations, and go for a run. This echoes advice that I've received from doctors in the past. Like myself, Tyra was sure they would not have suggested jogging if I hadn't been plus sized. So I draw our attention to some of these quotes as a way of understanding, first of all, the benefit of listening to lived experience in highlighting some of the issues with the healthcare system as it exists, and also the benefit of listening to marginalized people and minorities about their experience, their healthcare experiences, which often did cover a lot of very similar points. You know, this idea about having to manage the self-presentation, the idea of having a distinctly racist experience at the hands of healthcare professionals, and also about how different aspects of their identity performance changed the healthcare that they were able to receive. Next slide, please. Nikki also had experience of her appearance impacting her treatment. In her case, her doctor was reluctant to put her on antidepressants because she looked too well put together. My GP once said I looked too young to be in such pain. So now when I go in, I don't wear earrings, I don't wear lip gloss. I remember thinking that if I showed up with acrylic nails, they would think, so you can't work, but you have energy to get your nails done. Even though looking smart is a cultural and a gendered thing for Black women. We try to be presentable. Next slide, please. Nikki wished that her GP had given her more information about the side effects of taking antidepressants, as the stigma surrounding it in her community meant she couldn't speak openly about it. If you speak to friends or family from an African or Caribbean background who are already biased against medication, they're going to tell you to stop taking it immediately. If it wasn't for a friend with experience of medicating for bipolar 2 who told me to write it out, I would have quit, because my GP didn't give me that information, what to expect and when symptoms would come and go. They just said, see you in 2 weeks. Next slide, please. Since publication of my book, The Colour of Madness, I've been interested in both the issues with the lack of cultural competency at a treatment basis, but also cultural barriers to healthcare and medication, which I explore in my essay for So Hormonal, which I'll do a short reading from now. The essay is called Banana Leaf Poultices, Black British Attitudes to Healthcare and Medication. As the COVID-19 pandemic sweeps the world, my grandma tells me with some pride that back in Barbados, where the number of infections still remain in the low double figures and deaths in the single figures, people are returning to the old ways. An island of only 166 square miles, with a population of less than 300,000, served by just 2 main hospitals. She reminds me that quick access to medical care on the island is not always possible or affordable. So in her youth, preventative and holistic medicine was the staple. Lemon, ginger, and honey tea, sometimes spiked with rum for a cold. Poultices wrapped in banana leaves and held firm to the body to draw out infection. A spoonful of foul-smelling cod liver oil or black seed oil a day, and the dreaded bush tea for a clear out if you so much as fart in the vicinity of an elder. These are the medicines my grandparents brought with them from the Caribbean to the UK. The medicines of my parents' youth, and to a lesser extent, the medicines of mine. As an advocate for BAME mental health awareness and support, not to mention a user of prescription medication myself, my personal attitudes to mainstream healthcare are quite different to those of my parents and grandparents. I remain aware and critical of the ways in which healthcare systems underprivilege Black people globally and in the UK, through histories of non-consensual medical experimentation on Black people during and after times of slavery, non-consensual sterilizations, disproportionate diagnoses and criminalization of Black people with severe mental health conditions, and even now, the disproportionately high mortality rate of Black people infected with COVID-19. Even so, while I still practice the familiar home remedies when I have a cough, because that spiked tea is actually very nice and definitely effective, I'm also perfectly happy to go to my doctor, albeit after applying a little extra pressure to ensure I'm treated fairly. So in this extract, I conducted some more research with lots of different Black people, some of which remained anonymous and some which didn't, to ask them about the different attitudes that they'd experienced in their family towards lots of different aspects of healthcare and medication. So the majority of this, it came down to several different sorts of barriers, some which included family and culture, religion, talking about hormone treatments for gender non-conforming users, mental health, and also, I said religion, didn't I? Sexual health. So I'm going to read a little bit from some of those relevant parts. Dr. Samara Linton said that, I think the distrust for white colonial systems and medications mean Black people prefer to use alternative, holistic, natural medications. We think they're more real rather than chemical, and that they aren't part of a profit-based system in the same way drug companies can be. I also had bad eczema when I came to the UK, but I was never allowed to use steroid creams. It was always some other random cream we bought from the market. We don't tend to trust healthcare professionals, and often for good reason. Once my sister had this really bad rash and it wasn't getting better despite all of the things we were using, so my mom took her to the GP. The GP said they couldn't see it. This rash has been harassing my sister. It's bright as day, but she couldn't see it. So as a result, my sister hasn't seen a GP in ages. And even now, she thinks it's a waste of time. Mary said, I'm the type of person who thinks, let thy food be thy medicine and thy medicine be thy food. I'm very much in tune with what I put in my body and what effect it has on me. I have a big skepticism around big pharma because I'm aware it's a business. In order to keep themselves funded, they need people to be unwell. It's a system. That may be something I've internalized from my family. I'm British-born Ghanaian, and my parents moved from Ghana to here many years ago. One thing that made it quite difficult was that for me, as a PhD student with an insight into what research is like, I'm well aware that Black women like you and I are underrepresented in clinical trials of medicine. So I'm thinking, hold on, there's no guarantee that this will be right for me. And in terms of thinking about medication when it comes to depression, Rihanna Davis said, When I officially got diagnosed with severe depression and anxiety, it was a shock to my family. My mum and grandma were immediately really supportive and started reading about both diagnoses, but especially depression. I was already scared about taking antidepressants, I guess as an inherent cultural thing. I don't like taking tablets and was scared about the adjustment period. But my mum and grandma didn't want me to take them because they were worried about me turning into a zombie, being able to function but not being myself, or it having a long-lasting effect on my body. So in the end, I never took them and gave them to my friend one day who had run out of meds. My mum and grandma were also both nurses within the NHS, and they have an inherent distrust of Western medicine, especially psych medication, because they don't think they've seen it work. They're also both Christian, so I had to take some time to explain to them both when I got diagnosed that prayer is great, but I was also going to need more action than just that. And finally, my mum didn't take it well when I started antidepressants. She was scared because in her eyes, it's one thing to take physical medication and another to take medication that affects your brain. Every Black person she knows who takes brain-related medication isn't very well, is imprisoned or institutionalized. There are no positive examples for her. All she has is negative reference points. I had to convince her, reassure her. I had to become the expert in that situation. Now it's been a few years and she still doesn't love it. She'd never say, don't forget your meds. And once I found them in the bin, and I swear she did it on purpose. But they've realized it hasn't harmed my life in any way. And I feel like they're doing good. They kind of accept that. It's even reached the point where my mum has asked me to give my opinion to a friend thinking of going on similar medication. So we've come a long way. So I hope that some of those examples have given you some part of an insight into how some of those attitudes kind of affect our ability to access medication and healthcare, both within the group, both within our cultures and communities, but also in terms of accessing healthcare medication. Next slide, please.
Rihanna, we're running a bit short of time. I'm sorry to,
Okay, no problem.
Presentation. How about just doing a quick one on this slide? And if there's room at the end, we could probably...
This is the end of it anyway. So if we could just go straight to we'll stick on this slide, that's fine. So I'd just like us to think about how we can factor some of these understandings into our research and advocacy work. So part of some of the work that I'm involved in is with several lived experience councils, so including Project Neon, the Narrative Experience Online, which is a research study that's running until 2022, that tests how having online access to people's real life stories of recovery, stories like that, stories like those that are available in The Colour of Madness, might be helpful for people experience psychosis or other mental health problems and their carers. So the way that, as part of this, I'm on the Lived Experience Advisory Panel, where the central tenets of this are that we fully embed the perspectives of the people most affected by brain health research, both in the strategy and in the action to ensure that the real impact is made. There are multiple reasons for why we should integrate these lived experiences into our organization, into our research, because otherwise they will be left behind. We have to believe that there are moral, scientific, and economic reasons to incorporate people with lived experience into our research. That the people the research affects should have a say in the way that research is conducted, and that meaningfully engaging people with lived experience challenges historical power imbalances and progresses the way that we engage with research culture by valuing experiential knowledge in addition to those technical expertise or scientific knowledge. Thank you very much.
Wow, thank you, Rihanna. Really powerful. That was almost, to my mind, I might be corrected in a minute by our next speaker, but that was almost a definition of co-production. And our next speaker, Peter Beresford, is a real expert on that. I'm not sure if that's what you're speaking to us about today, Peter, but welcome.
Thanks ever so much. And hello, and I'm a bit anxious, and I'll have to read what I've got to say, and I ought to give a kind of a warning, because I think what I've been having to say, what I've had to talk about, I think is distressing. And it's not one little bit of it. I think the whole pattern is distressing. I just needed to say that. So I want to argue today that we are living under an unjust politics that is in close alliance with psychiatry, and yet which is at the same time a mad and maddening politics. I believe if we're going to improve things, we've got to understand and be clear about these realities and have a united and broad-based response to them, drawing on mad studies understandings to resist them, which challenge both the prevailing politics and psychiatry. So I want to explain what I mean by that. All politics tend to have a pattern to them. It's about a group of values and aims combined together. We are now living in a period of strong right-wing, or what's called neoliberal politics and ideology. Our Westminster government under Johnson, like that of Trump before him in the States, epitomizes this. It's based on cutting state support for people, increasing central control and restriction from the state, and demanding that people sort out their own difficulties rather than helping them with them. And also blaming, stigmatizing, and condemning people if they can't do that, and using the money it would have used to support them to increase wealth within a small privileged and powerful group and raise inequality and poverty for the rest. Now, when you have the chance to come to such a recognition, as I feel I have, what becomes very clear is that in a world governed by a politics of profit and wealth accumulation, not only is this a poor basis for taking care of people and them living the kind of life they might want to, as we've seen in previous periods of unrestricted market politics, like the Victorian period and between the world wars, and the exploitation, of course, of colonized nations and peoples, where there's much disease, early death, poverty, misery, and conflict. But of course, there's also unlikely to be much suitable provision made to help sort out actually increasing problems. And most important, government and state are likely to disclaim responsibility for those problems. So they will base their actions on attitudes, on individualized and blaming explanations, like it's your fault, you are unemployed, and not the loss of decent jobs, you aren't really sick or disabled, you could work if you really tried, you are a scrounger, lazy, unwilling to work. So social problems are rapidly seen as the individual's fault, their inadequacy or deviance, their idleness or incompetence. This is the politics we are living under here now. This is the politics of welfare reform and cuts, of homelessness, high-priced, inaccessible, poor quality housing, and so on. This is the politics of anxiety and uncertainty, undermining more and more people's lives and putting central responsibility on them for their difficulties at the same time. And during this time, we've seen in Western societies, the global north, an expansion of psychiatry and psychiatric ideas. Now, that doesn't necessarily mean an expansion in psychiatric support. I'd suggest more often the opposite and more controlling provision in what services there are, but it does mean a massive expansion and normalization of psychiatric type thinking. And this, with its ever enlarging DMS diagnosis book and more psychiatric categories of people to be included in them. And this is because, as we would expect of a discipline and profession rooted in a focus on the individual and their heads, it sees the problem as essentially within the person as a result of something that's wrong with them. And the routine responsibility we know is one of drugs, and when more than that is recognized, increasingly, sadly, mechanical and short-term approaches to what they used to call talking therapies, behavior modification like CBT in the cruder ways, cognitive behavior therapy. So more and more social problems have been reconstructed in psychiatric terms and diagnoses attached to them, and psychotropic drugs become the response of choice. From the problems that children and young people face in inadequate schooling and growing up, to the difficulties of older people placed in institutionalizing residential services, with all the racializing and other discriminations that go on within that. Education, growing up, aging, crime, unhappiness, and loss are now all increasingly permeated by psychiatrized understandings, explanations, and responses, and their social relations played down. There have now been for years of this far-reaching, there've now been years of this far-reaching, but I think also subtle process of individualizing social problems and pathologizing people. They've prepped people and publics, I believe, into accepting psychogenic explanations of their problems and apparently expecting less and less external help with them. So a worrying, undiscussed, informal alliance, I'm suggesting, has developed between damaging right-wing politics and inadequately evidenced and one-size-fits-all, as implemented, psychiatric approaches. There's also another no less worrying side to this issue, the way that such neoliberal states and governments are increasingly using psych techniques, legally and illegally, to get into and stay in power and undermine democratic process. We can see many international manifestations of this, from the US to Africa, South America to Central Europe. We saw it with Trump's electoral campaigns in the last UK general election and Brexit vote, with, people may remember, Cambridge Analytica's unpleasant illegal influence. And we're also seeing outside unfriendly states now exerting similar subversive influences on internal elections and related news, for instance, Russia. This can be seen as a psychiatrization of politics, where the minds and attitudes of key swing sections of the electorate are manipulated by misinformation and targeted messages, I'd argue, against their interests. This is the psychiatrizing, the psychoanalyzing of politics, remaking citizenship as a psychic status and degrading democracy by the psychiatric manipulation of its processes. In this way, the plan seems to be to impose neoliberalism without end on us and to prevent the possibility of more collectively motivated politics. Taken together, we're seeing neoliberal politics and psychiatric thinking teaming up, each serving the other's purpose. Now, we know from major studies that have legitimated, like the Spirit level, that inequality and the neoliberal politics I've talked about are bedmates. They make you sick and poor, but they're also maddening, these politics, in their consequences. They increase the pressure on us to madness and distress and reduce the resources, both personal and service-based, that could help us with it, encouraging the failing thinking instead of psychiatry to shape and distort our understanding of what's possible. But here I want to suggest that the problems are actually even more fundamental than this. Neoliberal politics are not just mad politics in the sense that they drive more and more of us to distress, madness, and even the contemplation or reality of death. The maddening nature of our present neoliberal politics, I think, goes far further. The world in the early 21st century is a heavily and increasingly conflicted and threatening place. It's characterized by international unrest, local and proxy wars, conflicts between faiths and ethnic groups, economic and forced migration, rising so-called natural disasters, including flooding and famine associated with climate change and human interventions, and pandemics originating at least in part from the mistreatment of animals. All these have consequences for our lives and well-being, including our emotional and mental well-being, and these consequences affect different groups differently, and of course are most damaging for those groups facing particular discrimination and oppression, like impoverished people, Black and minoritized people. We can't disconnect, I'm suggesting, our global mental health, ill health, from these pressures and threats. Instead, we should be exploring and highlighting their connections. As COVID-19 has particularly highlighted, the societies worst at dealing with public health issues tend to be those with the most uncontrolled, market-driven neoliberal ideologies and politics, like the US under Trump, us, and Brazil. The same, although less readily admitted, is equally true, of course, in relation to mental well-being. It too is strongly impacted on by political and social forces. Neoliberal politics are extreme, I believe, in their maddening consequences because of the pressures that they put most of us under and their withdrawal of collective support. But I think we can also say more than that, and I say this very seriously, they are themselves a mad politics. Of course, definitions of madness and distress vary over times, place and culture. The medicalization of madness and distress makes it even more complicated to understand and adds to the range of phenomena, experience, and perception included in the category. And there also, of course, have been and continue to be faith-based and spiritual conceptions of madness. Having said that, madness tends to be associated with a range of phenomena and behaviors, including loss of reason, unpredictability, threat, violence, possession, irrationality, failure to anticipate consequences, confusion, fearfulness, and of course, dangerousness. Neoliberal politics reflect the irrationality and threat that they accuse us of as mental health service users, survivors. They are the antithesis of all we are taught as children about love, kindness, cooperation, even co-production, honesty and fairness. What else can I say about a politics which now oversees and shapes a world of endless destructive war, fighting and killing, where people are expected to kill others by all means possible, sometimes including children, sometimes as children, of massive, damaging, world-destroying pollution and inadequate action against it, putting the future of the planet more and more species and fauna at risk. Some of the biggest and most powerful nations, of course, have the worst records in relation to the environment, where people are increasingly to be in damaging, alienating employment, while the constant aim actually also is to cut jobs, to reduce costs. And it now looks as though that will be happening at a massively increased rate with the negative expansion of artificial intelligence, AI, whereas so-called underclass of impoverished people has long been highlighted and vilified as deviant and destructive. A racialized underclass, I should stress, as it's presented, but where in reality, there's actually a small, overpowerful overclass beyond the constraints of conventional law, moral, ethical, and behavioral codes, where large numbers and increasing proportions of traumatized and oppressed people are maintained by a massive pharmaceutical industry, which is also related to the destructive arms and agribusiness industries, or turn to a massive exploitative, destructive and criminal illicit international drugs industry to try and sustain themselves, where far more is spent on armed forces and the arms industry than support for us to look after each other, where millions die from diseases that could be controlled, hunger and poverty that's created rather than alleviated, and from, quotes, natural disasters that are originated and perpetuated by human hands rather than averted by those. Free reign's been allowed to a global neoliberal system that puts money, profit and production before saving the planet and all dwelling on it. It is more a world of Dr. Strangelove, complete with mutually assured destruction, mad, than one based on any notion of human progress, sustainability critically, or cooperation. This would be described by madness by our psychiatric betters if it was associated with any individual, rather than with the states and statesmen, ideology and global politics that it represents. Put simply, in ordinary understandings, it looks like both a mad and maddening world. These are global problems, particularly affecting Black, Indigenous and minoritized groups and others facing discrimination and oppression. That's why we've got to work more and more beyond our own organizations and our own movements to make sense of these links with and political relations of madness and build, as I'm suggesting, such wider links between very different movements committed to the same liberatory, social justice-based collective action through our understanding of and acceptance of our diverse experience and a revaluing of our diverse identities and a revaluing of our lived experience. Thanks ever so much.
Thank you very much, Peter. That was so packed that I am very glad we're recording this, because I'm going to be listening to it again and again because there's so much information there. And it builds brilliantly on Imogen Tyler's talk last night, and reminds me also, I'm not sure if I'm allowed to do this, but a good friend and colleagues, Ellen Clifford's book, The War on Disabled People. I think, we could do a whole presentation on this, but I'm very excited to introduce now Helen Spandler.
Hi everyone. Just want to check that this is working okay.
Yes, I can see you loud and clear and hear you.
Okay, thanks. Hi everybody. Yeah, I wanted to. Sorry, I haven't got any slides. My university had a cyber attack, so I couldn't access any files to get any slides available today. So I'm going to have to read some notes. Basically, what I wanted to do in this space is to introduce the idea of a restorative justice approach to mental health reforms. And the starting point really is the well-rehearsed critiques of mental health systems that have gone on for ever since the inception of psychiatry and what we call the psy professions. And they're sort of, and I think there's been a number of issues: iatrogenic harm caused by medical systems like psychiatry, and also more recently ideas around epistemic injustice. So the injustice faced by people with lived experience of mental health issues, that their own experiential knowledge is discredited in various ways. So how can we move towards what we might call epistemic justice? So justice for people who have faced harms within the mental health system. And how can we use that to inform a more progressive mental health system and mental health policies? And I think my argument is that we can only really do that when the breadth and depth of harm that people feel that they've had can be articulated, acknowledged, and learnt from. In other words, that experiential knowledge is legitimated in some way. Now, in other contexts, people have argued that where there is a lack of evidence or conflicting evidence about the nature of a health condition and its treatment, as well as patient critiques of it, then patient perspectives should be privileged and prioritized. Now, whether you're pro or anti-psychiatry or anywhere in between, I don't think that we can disagree that there is conflicting evidence and there's a lack of evidence around mental health treatments and systems. So elsewhere, I've argued for a kind of truth and reconciliation approach to mental health systems, which is based on a kind of restorative justice approach. And a restorative justice approach has tended to be used in prisons primarily. And basically, what I'm arguing for is a grassroots, bottom-up, relational approach to mental health harms that's participatory and non-adversarial, which mimics a kind of approach to restorative justice approach to criminal justice, but it would have to be different because the mental health system is very different from the criminal justice system or other systems that have used a restorative justice approach. So there would be complexities in its applications because mental health systems are very different from other oppressive systems. One, it's not a monolithic system. There's a lot of diversity within it. There is no general acceptance of wrongdoing or who is responsible for the wrongdoing. And there's no necessary agreement on who is the victim and who is the perpetrator, or what systems are perpetrating harm, even amongst survivors and activists. So there's lots of potential applications of restorative justice approach and lots of potential issues that it raises. But I want to focus on one specifically here, and that is the twofold critique of the mental health system that we see. I think the dominant mental health activists by survivors approach it either two ways. Either a focus on psychiatric abuse, that psychiatry is over-controlling, use of detention, forced treatment, diagnosis. In other words, it's too interventionist. But on the other hand, we also see another critique around what we might call psychiatric neglect. And that has been intensified in relation to austerity and neoliberal kind of politics, where mental health services are inaccessible, there are long waiting lists, recovery model which discharges patient long-term service users and survivors. discharging patients too early. And there's been quite a few scandals in relation to this over the past few years, where people feel that service users have been discharged or cut from services too early, or not able to get admitted to hospital. So what we see here is a mobilization of two what might be seen as contradictory critiques. So on the one hand, the right to refuse treatment, to not have treatment, but on the other hand, the right to receive treatment. So you might call them positive and negative rights. So for example, this applies across the board in relation to mental health systems, in relation to detention. For example, some service users find detention a human rights violation, and that has been to some extent endorsed within certain sections of the United Nations Convention on the Rights of People with Disabilities. Some service users would feel like they need to be detained, even against their will, in circumstances where they lose capacity. ECT is a hugely controversial treatment that some patients feel that it has ruined their lives, some patients feel that it has saved their lives, and you can't get any more diametrically opposed than that. Things like chronic fatigue syndrome, the dominant approach to which has been heavily contested as psychosocial and not biomedical enough. Psychiatric medications and diagnoses, you can argue the same. And what I'm arguing really is that we have a split that's probably a third in relation to most of those issues, in that some people feel that psychiatry has damaged them, another maybe third feel like it's actually helped them, and maybe another third which feels like it's maybe had little or no effect. And what I'm suggesting is that all those perspectives need to be heard. And they might be called, we might be able to refer to them as what I'm calling paradoxical truths. And a paradox is something that seems contradictory and conflicting on the surface, but actually reveals an underlying truth. And what I'm beginning to think about now is how they are all partial truths, and they can all be true. For example, it is possible that it is entirely possible that detention is both a human rights violation in some contexts and a lifesaver in other contexts. And the same might be said about diagnosis, medication, treatment, and various forms of treatments. The problem is when we use binary logic and we believe that only one of those must be true and the others mustn't be true. Or when we impose an idea based on our own perspective when there is little evidence to back it up, which, as we've said, evidence is hugely equivocal. And when that happens, we tend to ignore, deny, or attack perspectives that are in opposition to our own. So if we truly believe that there is paradoxical perspective, there is a paradoxical truth, and that we need to take into account survivor perspectives of all sorts and of all sorts of harm, including psychiatric abuse and psychiatric neglect, then we need a framework to support the articulation of various forms of epistemic injustices through survivor testimony. So a restorative justice approach to mental health reform would seek to provide safe ways in which people who have felt harmed by the system, or even helped by the mental health system in whatever ways, for example, through psychiatric abuse and or psychiatric neglect, would have a chance to be heard and their stories heard in full, and to also hear other perspectives, and for policymakers, workers, staff, and researchers to listen and hear those perspectives in all their diversity and all their conflict, and to provide a container for those perspectives. A restorative justice approach has to have important elements. One, they have to be voluntary. Otherwise, if they're forced, it mimics certain aspects of the mental health system that we would probably want to minimize, at least. That people are heard without interruption. I remember being at one radical mental health conference where one service user was talking about their experience and happened to mention a psychiatrist that she thought was a good her psychiatrist, which she felt was a good psychiatrist, who used ECT, and the whole crowd in the audience booed her And that's, I remember, thanks Ed, that's at the point I remember thinking, we cannot go on like this. We cannot be saying that we're having a radical perspective on mental health when we shut down service user perspectives when we don't agree with them. So it also has to be, it can't, you know, has to be a safe space where people aren't into arguing about who's right and who's wrong. If we see that everybody's truth as being a partial truth and revealing something more profound about the human condition and mental health systems themselves. And it must also not be framed in a psychiatric or psychological or treatment focused way. So it would need to be mediated by someone not within psychiatry or psychology or psychotherapy, but someone expert in restorative justice approaches and conflict mediation. It would also not seek to have predetermined outcomes. So you wouldn't say, right, we want to do this because we want to prove that this is the wrong thing to do, or this is bad and this is right and this is wrong. And we mustn't also try and preempt or impose new models or seek premature solutions, because I think these things take a lot of time and we can't jump to conclusions until we hear the breadth and depth of people's experiences. So I'm aware of time, and I just want to give a few examples of these kind of approaches. It was interesting that Imogen Tyler in her keynote talk yesterday talked about the Poverty and Truth Commission that she's been involved in Lancaster is now a National Poverty and Truth Commission, where people, even people who work in things like the DWP, which is a bone of contention for many mental health service users, are able to hear the perspective of people who need social security and what those systems are like for people in deprivation and poverty. And I think that's an interesting model to think about how we might apply that. We've talked about a truth and reconciliation approach, which some are still seeking to achieve using the UN Convention of Rights of People with Disabilities. And I know there's some moves to do that. And I know some service users are starting to talk about truth and reconciliation restorative justice approaches. And we've been talking to trade unions and service user groups about this. In the States, UK, the Rethinking Psychiatry group and the Old Icarus project got together to have a number of short, what they call healing circles around these issues. And there's a link, I think, that Ed might put in around that on the Mad in America site, written by Rachel Levy. And there's an organisation called Safely Held Spaces in the UK, which are working along these lines, working with family members and service users and survivors around thinking about what safe spaces might be to think about and talk about distressing experiences. And finally, I just want to mention Asylum Magazine, which is the magazine I edit. And we try and publish a range of critiques of the mental health system that don't have a particular ideology or particular framework in mind. And I hear from many service users with different sorts of experiences, and they don't always meet with what I might believe in or what other people might believe in. And finally, zines. I've been doing some work on radical mental health zines and zines, where people's personal experiences are turned into zines. And the good thing about that is you get a real diversity of people's perspectives that aren't necessarily framed through a particular ideology or perspective. And I think if we can hear the diversity of those experiences, so I believe that there's many different ways as researchers we can try and access epistemic knowledges that we need to legitimate. So I'll leave it there. I think that's about 15 minutes. Thank you.
Thank you, Helen. That again, powerful. And there's another, your viewers, you'll have another opportunity to hear Helen speak this afternoon in our 4 o'clock session. So she'll be talking about lesbians and the hidden history of lesbians and psychiatry. Sorry if I garbled that, Helen, but I'm really looking forward to it. There's some really interesting comments coming in on the Padlet scheme. Please, if you haven't had a chance to drop any of your thoughts in there, do when you get a moment, and we'll have a bit of a pause after Dorothy, our final speaker. But welcome my friend and colleague Dorothy Gould.
Thank you, Annie. Just to say, and if we could have the first slide up, I'm going to be talking today about perspectives of service users and survivors from LGBTQ plus communities, that we want to have equal power with other people, but often it just seems as if we're very invisible. Could I have the next slide, please? Just to let you know what I'll be covering, I'm going to be talking about sources of discrimination, about intersecting discrimination, where people face it on more than one front and its devastating effects, very much like Peter was talking about, for example. Positive and negative experiences of contributing to or leading research on LGBTQ plus issues. Difficulties for us in achieving equality and joining fully in with other members of the community. And also a little bit about what we can do about this. I mean, what are the openings? What are the opportunities? Next slide, please. A huge concern is the fact that discrimination is so embedded in the whole structures of society. For example, at government level, I mean, I guess a lot of people who are listening will know that members of the government's LGBT advisory panel recently resigned on the incredibly worrying and you'd think unbelievable grounds that the government is creating a hostile environment for LGBT plus people. Also concerns about support services. I mean, a lot of us don't do very well there in terms of our sexual orientation or trans identity. But again, there's this invisibility. There's been a really concerning lack of focus on specific issues for LGBTQ plus communities during the coronavirus pandemic. And yet there've been some very particular issues which we faced. And again, within society as a whole, hate crime is actually going up, not down. So in other words, things are going in the wrong direction at society level as well. And I'm going to illustrate this in a minute with some quotes from the LGBT Foundation. Next slide, please. These are some things that people who contributed to the Foundation's research said. I can't be myself. I can't come out, and it's hurting inside. Prior to the COVID-19 crisis, I was due to move out into supported living, where I can gain access with my mental health. But now, this lockdown, I'm stuck in limbo. So this is where you see the dual discrimination, the intersectional discrimination, how it can affect those of us who both identify as service users or survivors of mental health services, but also as LGBT or T. The second quote, which again shows how relevant race issues are as well. As an LGBT Muslim family, relationships are already strained. So relying on family during this time can be difficult, if not impossible. But again, that issue has not been addressed during the coronavirus pandemic. And a third person, this time someone who's trans, I can no longer speak with my friends in a safe environment about my mental health. Being transgender in a household that doesn't accept me is difficult. But before isolation, I could escape to a friend's house for support. Next slide, please. Recent legal developments are also very worrying and are worsening the situation. For example, the review of the Mental Health Act 1983, and now the white paper based on that review. A concern about the review is that on an ongoing basis, and also in the report, there's been virtually no mention of issues for LGBTQ plus people who use mental health services, And that shortfall is despite the fact that there's extensive survey and focus group data that's available. And that's not for lack of raising the issue. Those of us who identify as mental health service users and survivors and as LGBTQ+, voiced our concerns right through the review and also during the period leading up to the publication of the Mental Health Act White Paper. I guess most people here will know that that came out in January. But because our concerns haven't been addressed, the shortcoming on issues for LGBTQ+ service users and survivors is now also reflected in the Mental Health Act White Paper. Next slide, please. Moving on to research, a particular concern is the fact that we're represented in so few research studies. That's discriminatory in itself. There is a certain amount of evidence, but it's very limited. The shortfall extends to studies which are specifically also about issues for people with mental health diagnoses. A slightly cheering note is that there are one or two small recent studies led by people with lived experience of mental distress, which do put a focus on LGBTQ+ issues. To mention one which actually had the lead for myself, that was the Healthy Lives Project, and also a study from Middlesex University called Keeping Control. Next slide, please. To say a little bit more about the Healthy Lives Project, this was a study which focused on the physical healthcare experiences of people given a serious mental health diagnosis. We did put an emphasis on hearing from a really diverse range of participants, including LGBT participants. Sadly, there was opposition to that. When I wrote up the data, I was strongly criticised for bringing that into the research. So again, it's that sort of bias again, which is deeply troubling. But to give a couple of quotes from the Healthy Lives Project, one is, I've had bad experiences with nurses and GPs, assuming I'm heterosexual, and asking what I felt to be intrusive questions about contraception, and not believing me that I've never had sexual intercourse with a man. One person who particularly appreciated a facility that he had found available, the sexual health clinic has like a gay men's only and a gay men's drop-in session, which I always found quite helpful because you don't have that awkward waiting room kind of experience because it's specialist doctors and the same kind of group. And then a comment on training. I did want to say that I think GPs do need more training about like diversity and stuff. Next slide, please. Moving on to the Keeping Control study. This was a user-led study at Middlesex University, which was also done in a co-productive style. And what it was exploring was mental health service users' experiences of targeted abuse, prevention and protection in the context of safeguarding reforms brought in under the Care Act of 2014. One person commented on the fact that issues are dealt with singly, not together, but you have to look at the sort of the whole picture and the fact that people are whole people. So this participant said, I think the government needs to look, or the agencies, the various agencies need to look into the association between the three, LGBT, mental health and hate crimes, because I think those are three things which are all treated as separate issues. but they're actually one big issue. And then another participant sadly blaming herself. This was a trans woman, and like a lot of us do when we're abused, we kind of blame ourselves, think it must be something to do with our fault. So what she said was, part of me probably still thinks I shouldn't put myself in that situation. She was being abused. So there's blame there as well, I think. Next slide, please. And I also wanted to share a little bit about what happened in focus groups for the Mental Health Act review. An Asian colleague and I facilitated a couple of focus groups for people from Black, Asian and other minority ethnic communities. And again, we covered sexual orientation and trans issues. The sorts of responses we got are very much reflected in the two here. If the person is biased or racist or homophobic, they're more likely to section you because of who you are. And then another participant said, there's a triple penalty if you're BME, a Muslim, Sikh or Christian, and a woman or gay. And for facilitators, but also of course for focus group members equally, it was devastating that the review wasn't willing to make use of the way people poured out their hearts on the issues facing them on sexual orientation and trans front. Next slide, please. So I'm going to move on to a vision for social equality, and that very much centres on the UN Convention on the Rights of Persons with Disabilities, which has also been mentioned earlier in this session. It's a convention that's enormously important to many of us who are disabled, including users and survivors of mental health services, because unusually we actually played a major part in the focus it took and in its content. Next slide, please. The convention fully recognises that individual and structural discrimination do occur, would recognise that LGBTQ+ people often experience particularly high levels of mental distress because of those factors, and then of course are labelled mentally ill. The convention in turn gives full weight to the fact that being labelled mentally ill often leads to political, social and economic disadvantages, ones which are compounded by intersectional discrimination. So Article 5 of the UNCRPD is particularly important because it focuses strongly on the need to address inequality. Next slide, please. As part of the vision drawn from the CRPD, what I'd like to see is a much more rights-based set of law, particularly law based on the UNCRPD. Important and valuable though the European Convention on Human Rights has been, it's much older in origin and it doesn't address so specifically the issues that we face. But at the same time, UK law is based on that convention with very limited account taken of the CRPD. Because if you identify as LGBTQ+ and use mental health services, there's a long history of saying, well, you're mentally ill because you identify as LGBTQ+. And that actually is still around today. We have a particular investment, many of us, on the fact that the CRPD proposes an end being put to involuntary detention and false treatment. In that sense, it goes well beyond the Mental Health Act White Paper, which proposes continuing with those, although on a reduced scale. Next slide. A further major strength for many of us is the UNCRPD's call for equality through social transformation. This recognition that it's the way society is functioning that is a problem. So, for example, in Article 19, there's a strong emphasis on us also being able to live independently in the community with the support we need to achieve that. And whether that's purely because we have a sort of single disability, or whether we're also facing intersectional discrimination based, for example, on sexual orientation. Article 19 and other articles also call for us to have the same opportunities for community involvement as anyone else, and emphasize that if this social transformation is going to be achieved, it's vital that user-led groups are involved in changes needed to law, policy and decision-making. Thank you. Next slide, please. So to move on to where I think there are some openings and opportunities, really wanted to underline that the UNCRPD itself was achieved through genuine partnership. That was a partnership by experts without lived experience of disability and organisations led by disabled people. And that actually included people who would identify as LGBTQ+. And, you know, if that could happen with the UNCRPD, then it can happen elsewhere. There are very real challenges in such partnerships, but they are possible. I think there are also real opportunities if LGBTQ+ service users and survivors join forces with other powerful movements like Black Lives Matter and campaigns for women's rights. And also, although there may be fewer politicians, professionals and academics without lived experience who are genuinely supportive of LGBTQ+ service users survivors, they do exist. And my hope and my feeling is that many of you here today actually are very supportive of us, and it would be absolutely brilliant to have partnerships with you. Final slide, please. So really just to say thank you for listening, and I'll really look forward to feedback. Thank you.